Chapter 18, Managing Anxiety. What is anxiety? Anxiety is a feeling of uneasiness, uncertainty, and helplessness. This is a normal emotional response if it's a real or imagined threat or stressor. Okay, this is a normal emotional response. I mean, everybody gets anxiety, right? And this could actually be a good thing. Sometimes it serves good purposes, like it's a warning of impending danger. Okay? Mild anxiety also can actually increase learning because it enhances the concentration and focus of the person. However, the problem is that when there is that uncontrolled anxiety, that's when it becomes a what we call maladaptive behavior, right? But otherwise, mild anxiety is really good. It's a warning for impending danger, and it's a normal part of the survival and growth. In page 205, table 18.1, the book talk about levels of anxiety. You have the mild, moderate, severe, and the panic, and we need to know the physical manifestations and the cognitive and perceptual, emotional, and behavioral. So know and highlight this table 18.1. In that same page 205, there is a continuum of anxiety response where one side is the adaptive response and the other side is maladaptive responses. These are the maladaptive responses is the ineffective attempts to cope for anxiety. All right, anxiety occurs as the result of a perceived threat to oneself. So we have types of anxiety, and please know the difference. Signal anxiety is the learned response to an anticipated event. For example, you're going to take the ATI exam, right? That's a signal anxiety. There's an anticipated event. That's why you have that anxiety. Then you have anxiety state is an individual's coping abilities become overwhelmed and there's an emotional loss of control. That is what we call anxiety state or state of being in the anxiety. And then you have anxiety trait, which is a learned component of the personality of the anxiety. One example of this is that you know maybe you're talking to a patient, right, and the patient is like trying to give you reason already even though you're not asking them. Like for example, you walked into the room and then the patient would be like, I'm not doing anything, right, even though you didn't even ask for explanation. Okay, that's an anxiety trait. It's a learned component of the personality. Okay, physical symptoms of anxiety, there will be muscle tension, patient will be fidgeting, headache, they will even have problems with sleeping, and then the fight or flight reaction is going to be activated, right? Coping methods, coping mechanisms in the physical realm includes efforts to directly face and handle the problem. So it's very important when we're talking about anxiety response, the coping methods, coping mechanisms of the patient that has the anxiety is very important because this is how they will handle the situation. This is how they will handle the this manifestation of anxiety. Defense mechanism are those strategies, psychological strategies that help to lessen feelings of anxiety. The goal for defense mechanism is to reduce uncomfortable negative emotion. And then crisis is when one's ability to cope with anxiety is overwhelmed. So what we need to do or the patient needs to do for crisis is to develop new coping behaviors to successfully solve the source of the problem to get out of that crisis mode. All right, 18.2 are common defense mechanisms, and we have to know them, okay? It's in page 206 and 207. We need to know every single one of these common defense mechanisms. Compensation is the attempt to overcome feelings of inferiority or make up for deficiency. Compensation, one example is a girl who thinks she cannot sing, studies to become an expert pianist, right? So she cannot sing, so she actually she became an expert on something else. That's compensation. Conversion is channeling of unbearable anxieties into body signs and symptoms. So, one example is a boy who injured an animal by kicking it develops a painful limp. Right? Denial is refusal to acknowledge conflict and thus escaping reality of the situation. For example, a child covered with chocolate refuses to admit eating the candy. Denial. The displacement is redirecting of energies to another person or object. So, for example, a husband shouts at his wife. The wife then now shouts at the child. The child now then scolds the dog. Okay, displacement is like redirecting energy to another person or object. Dissociation is separation of emotions from the situation. Removal of painful anxieties from conscious awareness. So one example is when a teen casually describes the auto accident in which he lost his legs. Fantasy is a distortion of unacceptable wishes or behaviors. One example is when a teenager is doing poorly in school, they dreams about owning a private jet. Identification is taking on personal characteristics of admired person to conceal own feelings of inadequacy. One example is when an adolescent like dress and behaves like the members of a popular singing group. Intellectualization is focusing of attention on technical or logical aspects of threatening situation. One example is a wife describes the details of nurses' unsuccessful attempts to prevent the death of her husband. Isolation is separation of anxious feelings from content to cope unemotionally with topics that would normally be overwhelming. Like, for example, a soldier humorously describes how he was seriously wounded in combat. We call it isolation. Projection is putting of one's unacceptable thoughts, wishes, emotions onto others. Example is when a woman is afraid to leave her house because she knows people will ridicule her. Rationalization is use of a good, but not real, reason to explain behavior to make unacceptable motivation more acceptable. One example is a student that justifies failing an examination by saying that there was too much material to cover. All right, the next one is reaction formation, development of conscious attitudes and behaviors patterns that are opposite to what one really would like to have. For example, a young man with homosexual feelings, which he finds to be threatening, engages in excessive heterosexual activity. Regression, we know this from PEDS, right? Coping with present conflict or stress by returning to an earlier, more secure stage of life. For example, it's a 4-year-old whose parents are going through a divorce, starts to suck his thumb and wet his pants. Restitution is giving back to resolve guilty feelings. Example is a man argues with his wife and then buys her roses. Sublimation is unconscious channeling of unacceptable behaviors into constructive, more socially approved areas. Example is a hostile young man who enjoys fighting becomes a football player. Substitution is suppressing anxiety by replacing inappropriate behavior with one that is more acceptable. Example is a man who is attracted to pornography campaigns to ban adult bookstores in his community. Suppression is removal of conflict by removing anxiety from consciousness. Example is a woman with a family history of breast cancer forgets her appointment for a mammogram. And then symbolization is use of an unrelated object to represent hidden idea. Example is a girl who feels insignificant draws a picture of her family in which she is the smallest character. Undoing is an inappropriate behavior that is followed by acts to take away or reverse action and decrease guilt and anxiety. Example is a man who physically abuses his wife and then cleans her wounds and nurses her back to health. So this table 18.2 is very important for us to remember common defense mechanisms, what is their definition, and then the example of those defense mechanisms. Self-awareness and anxiety. Important to remember that anxiety is contagious. So, as caregivers, we need to recognize and cope effectively with our own anxieties, right? Because if you're taking care of a patient, for example, maybe a patient that has a terminal illness, or maybe a little child, right? If you have a patient that's a little child, if they can see that you're anxious as a caregiver, they will be anxious too. So, as caregivers, we have to remain that professionalism, even though, yes, we can have anxiety. We're humans too, it's normal. Like what's in this PowerPoint, it says we may not choose our anxieties, but we do choose how we deal with them. You do not want to be the one that's freaking out in front of a patient, right? Because, like we said, anxiety is contagious. The more anxious that you show other people, the more anxious they will be too. Okay, there's some theories that's related to anxiety. You have biological. Biological is the one that is actually has something to do with the biological, like chemical imbalances of the body, and then physical basis of the anxiety too. Like for example, Darwin, right? He links the emotion and the ability to adapt. For Hans Selye that we did just talk about already, there's like a fight or flight response. Like your pupil will be dilated, you will have increased BP, increased heart rate. So those are like biological models. Psychodynamic models, when the anxiety results from a conflict between two opposing forces within an individual. You remember the ego and the id and the superego. And then you have interpersonal, which is anxiety is explained in terms of interaction with others. Okay, interaction with others. So, for example, with this one, Sullivan believed that children acquire the values of their parents because they are dependent on others for approval or disapproval. Then you have behavioral theories, which consider anxiety as a learned response. So, for example, an anxiety that results when a person encounter a signal that reminds them of an earlier anxious time, right? They already had that experience before, so it's a learned behavior. So now you're gonna have that anxiety as well because you know what to expect. And then other models, you have existential and holistic. Existential is when the anxiety that results from a loss of life's meaning. Holistic views anxiety from the holistic perspective. Okay, anxiety throughout the life cycle. So adolescent up to older adult, right? Adolescents who ineffectively cope with anxiety often express themselves inappropriately. Many instances there will be like schizophrenia and psychosis. This is when we start seeing those initial symptoms because of anxiety, right, and some other emotional disturbances that the adolescent is going through. Healthcare providers who work with adolescents must assess adolescents' anxiety levels and offer early intervention and education. This part right here is very important, okay? We need to have that early intervention and education. Anxiety in adulthood, this is similar to the younger counterparts. However, the adults handle anxiety by actually using experiences, right? Those established coping mechanisms due to their experiences. Developmental tasks such as establishing a career and family, that's the most common anxiety around this time during adulthood. When adult anxieties are not successfully managed, a number of mental health problems may result. Older adulthood, elders often deny their anxiety. So that's why it's kind of like tricky and challenging for us to be able to catch or diagnose anxiety in adulthood, in older adulthood, because they usually deny the anxiety. One of the most effective methods for assessing anxiety in adults, though, is to simply ask the patient to explain his or her anxious feeling. Have the therapeutic communication that we already learned, right? Have them elaborate how they're feeling. Older adults usually appreciate the interest of concerned caregivers. Anxiety disorder. So, diagnosis of an anxiety disorder is based on a description of the behaviors that express distress. Sorry about that. You have what we call the generalized anxiety disorder, right? Your GAD. This is when the individual's anxiety is broad, long lasting, and excessive. We call it generalized anxiety disorder. They are worried and anxious more often than not. And then you have panic disorders. This is more common than once thought. You have two types of panic disorder. Either it's associated with agoraphobia or not associated with agoraphobia. Now, what is agoraphobia? Agoraphobia, right here, is actually when the person or avoids people, places, or even events that which escape would be difficult or embarrassing. So they're like freaking out. These are those people that actually would go out and they're actually fixated on where the exit is, right? Because with people with agoraphobia, they're really scared and they get really anxious when they are put in a position or place where an escape would be difficult or embarrassing. So two types of the panic disorder. One is associated with that, the agoraphobia, and another one that's not associated with agoraphobia. Now we have phobia, right? Phobia is an internal fear reaction. Fear that is very obsessive in nature to the point where a normal person would actually that don't have phobia actually going to be scared of something, but not to the extent where a phobia is actually obsessive in nature. For example, those patients that actually scared of, I don't know, maybe a spider, right? Yes, it is scary from even with other people, but then with people that have phobia, they are very obsessed. It's obsessive in nature with the anxiety that they're feeling. Okay, people with phobias handle their anxieties ineffectively, and characteristics of phobia vary with culture. Then we have obsessive compulsive disorder. This is specific behaviors that must be performed to reduce anxiety. One example I can think of are those people that actually would be super that has an OCD for maybe scared of being infected with something, and then they would want to like wash their hands 100 times a day, and they have to be performing that specific behavior of washing their hands to help them reduce their anxiety. Otherwise, if they don't do it, then they will be anxious. Okay, most common obsessions are related to cleanliness, like I just said, dirt and germs, aggressive and sexual impulses, health concerns, safety concerns, and order and symmetry. All right, there's more anxiety disorders: your body dysmorphic disorder, hoarding disorder, hair pulling, excoriation disorder or skin picking, and then behavioral addiction. Okay, body dysmorphic disorder. This is when the patient become obsessed with a perceived flaw in their body. Like for example, some features in their body, they become very fixated on that, and then they become very obsessed that something is wrong with that feature. For example, a patient that has a flaw, or they think that they have a flaw with their nose, so they will be very obsessed with trying to fix the nose, right? Maybe going into surgery after surgery after surgery, because in their mind, or what they see, or in their mind, they're thinking that something's wrong, right? That's why it's called body dysmorphic disorder. Hoarding disorder. For body dysmorphic disorder, how do we help them? How do we treat them? Then we can actually give them antidepressant, is also is helping with this type of anxiety disorder, and then we can also have them go through a behavioral therapy, like your psychotherapist, right? Hoarding disorder is when the patient is actually having so much trouble discarding or throwing away possessions, even though they don't have any value anymore. Right? So now they end up hoarding or just keeping those um, items that don't have value anymore. How do we treat hoarding disorder? We give them antidepressant and psychotherapy. Okay, they need to go through rehab, not just the medication, um, but they need to go through the psychotherapy. What they do is they actually help with those people that would actually slowly help them with letting go or parting from the, whatever it is, the possessions that they're trying to hoard, and then eventually, slowly the patient will be able to live and be okay without those possessions. And then we have hair pulling, which is what we call trichotillomania. This one is the excessive and persistent pulling of the hair from the body despite the efforts to stop. So some of them might be mild, some of them may be really bad, where the patient is going to have those bald spots already and even infections. Treatment is focused on changing the self-destructive behaviors. What we can do is we can have them cognitive and acceptance therapies. Again, antidepressant may help also. And then excoriation disorder or skin picking, just like the hair pulling. The only difference is that they are picking their skin to the point where the skin would actually be have open areas like lesions. There will be tissue damage, and sometimes even the scabs, right? When there's scabs already, they will start to pick that. But then the main problem here is that, that's the skin, that's the, part of that's the part of the body that's actually stopping or preventing infection. But because they keep picking the skin, they're at high risk for infection. And how do we treat this? We can actually help them by giving them psychotherapy, or helping them and referring them to psychotherapy again and support groups. And then making sure that we're preventing the infection, because that's the most important thing as well, in addition to the psychotherapy need that the patient will have to go through. And then behavior addiction. So this is when, of course, there's like an obsessive compulsive activity that they are actually used to. Like for example, gambling, right? Or shopping, or even working. Okay, so those are behavioral addiction because they become too addicted to that behavior, and it gets it becomes like a compulsive way of living. So we can have referral also for psychotherapies for those patients that has behavioral addiction. However, the main challenge here is that most of those people or patients that have this behavioral addiction, they don't actually want help. So the patient needs to want to have that help in order for us to have that successful management and treatment of the addiction. Okay, now we have traumatic stress reaction and post-traumatic stress disorder. Traumatic stress reaction is a series of behavioral and emotional responses that follow an overwhelmingly stressful event. Okay, there's an overwhelmingly stressful event that, and then traumatic stress reaction follows. Now, you have what we call PTSD or post-traumatic stress disorder. This one is relieving and relieving and relieving of that traumatic events or situations. They keep having those flashbacks, is what we call it, right? And this is actually very disabling to the patient because they will have constant anxiety, depression, and nightmares because of those flashbacks that's happening after that overwhelmingly stressful event. Mm, So, therapeutic interventions, prevention is the most effective way to cope with anxiety. If we can prevent it, then yes, we have to prevent it. But we also have mental health therapies and medications that we can use as treatment. Um, there's what we call CBT or your cognitive behavioral therapy. This helps patients intellectually understand the behaviors, the ineffective behaviors that they are actually using. And then they will have to replace it with a more successful behavior. So that's cognitive behavioral therapy. It's like realizing first what is wrong, right? You have to understand, the patient needs to understand that ineffective behavior that they have, and the ineffective way for them to actually cope with anxiety and then replacing it with a more successful behavior. Then we have systematic desensitization and then flooding. Okay, these two right here. Here's the difference. For systematic desensitization, the patient will be slowly and gradually be exposed to that distress causing event, so that the patient can actually develop that effective way of controlling that anxiety, right? Systematic desensitization is slowly and gradually right here. For example, you have a patient that has a phobia, right? Right here. So, for example, you have a patient that has a phobia. For desensitization, is that you are actually going to gradually and slowly expose them to that um, place or event or maybe an animal that the patient is actually has a phobia to. Flooding, however, is just the opposite of desensitization. This flooding is when we're treating anxiety, like for example, the phobia, rapidly and repeatedly exposes the patient to that feared object or the situation until the anxiety levels diminish. So it's like the opposite of desensitization. Desensitization is gradual and slow, while flooding is actually like rapid and repeatedly, right? Okay, now anxiety may also be treated by various medications. You have benzodiazepines, you have antidepressant, antihistamines, and then propranolol, which is a beta blocker, and then some anxiolytics also we can do. In table 18.3, these are the side effects of benzodiazepines and nursing care. So know the side effects of benzo. Remember that this benzodiazepine is actually decreasing the central nervous system. So you will have those effects in the in the central nervous system that causes like dizziness, drowsiness, and all of those things. And then know the nursing intervention and therapeutic intervention that we do or we put in place to actually address the side effects of that benzo, right? So please um, study this table 18.3. And then in the next page, which is 216, table 18.4, these are the side effects of the drugs that is used to treat anxiety. So like antihistamine, benzodiazepine, SSRI, which is your selective serotonin reuptake inhibitor, and then buspirone or your Buspar and Vanspar. So know the side effects so that we would know, or you would know, the nursing intervention, how we actually manage or make sure that the patient is actually safe when they're taking these medications.